Good morning, everyone. Welcome to episode 32 of the Breakfast at UMHealth live webinar series. I'm Prasath from the Department of Biomedical Imaging, and I'll be the moderator for today's session. We have only one topic for today. Thus, my colleague Dr. Hazwan Amzar will be taking all the limelight for himself with his talk titled Imaging in Traumatic Cervical Spine Injury. During the talk, if you have any questions, please type them in the Q&A box below. And after the talk, if time permits, I will select a few questions to be answered. Dr. Hazwan is the newest addition to our radiology family in University Malaya. He hails from Subang Jaya, went to medical school in IMU, and completed his master's in radiology in University Malaya in 2019. He has an interest in musculoskeletal radiology and is currently working towards his goal in pursuance of this field of interest. Without further ado, the floor is yours, Hazwan.
All right. Thank you for the kind introduction, Prasath. Just give me 1 second to share my screen. Okay. So once again, I'm Dr. Hazwan. I'm a clinical radiologist and a medical lecturer from the Department of Biomedical Imaging. So today I'll be talking about imaging, specifically in traumatic cervical spine injury, which I think is a very common thing we encounter in our daily practice, and it'll be good to talk about and refresh about it. Okay. So this is the contents for the presentation today. First, we'll touch a bit about clinical assessment. Then we talk about the imaging modalities and the normal anatomy. And then we'll go to the types of common injuries. So first of all, clinical assessment, I won't be going through specifically what you need to look out for. I think our clinical colleagues will be very familiar with this. But I just want to touch on decision rules to decide whether your patient requires imaging for the cervical spine. So as imaging is not useful as a screening tool because it's not cost beneficial and it exposes patients to unnecessary radiation. So by using some decision rules, we can reduce unnecessary imaging and reserve them for patients with a higher likelihood of having clinically important injuries. So two very common decision rules which have been validated in large sample size and is recommended in many international guidelines are the Nexus criteria and the Canadian C-spine rule. So between these two, however, there's no consensus on which is better or superior or more recommended. Okay, so first of all, we go to Nexus criteria. So Nexus criteria, there are 5 criteria, and all of these need to be absent for the patient to be excluded from imaging. If any one of these is present, then patient is warranted for imaging of the cervical spine. So you notice for Nexus criteria, the 2 main highlights is the cervical spine tenderness in the midline, as well as focal neurological deficit. So the other 3 criteria are anything that may obscure your findings of these first 2, such as intoxication, distracting injury, or altered mental status. So Nexus criteria has a very high sensitivity of 99%, and studies have shown that it safely reduced imaging by 12.6%. There is no age limit mentioned in the Nexus criteria compared to the Canadian C-spine rule. However, some studies in elderly patients aged more than 65-year-old have found that sensitivity is more variable, ranging from 66 to 100%. So in this subset of patients, perhaps we might want to use a different rule, which is the Canadian C-spine rule. It has also been shown to have a very high sensitivity, in this case 100%, and studies have shown that it has managed to give a relative reduction of radiography by 15.5%. So this is the outline of the Canadian C-spine rule. Basically, I like how it's presented in this flow chart. There are 3 main questions that need to be answered. So any high-risk factors, such as listed here? If yes, radiography. No? Okay, go to the next question. Any low-risk factors which allows safe assessment for the patient's range of motion? Yes? Okay, then go to question 3. No, radiography. So finally, is the patient able to actively rotate the neck 45 degrees left and right? Yes, then okay, good. You can exclude patient from imaging. No, patients are unable to do it, then to radiography. All right. So now that we have some guidelines to indicate whether does the patient require imaging or not, now we'll go through the imaging modalities and their anatomy. So one thing to decide is, are you going to do a cervical spine radiograph, or are you going to proceed to CT? So some things to consider is this a low risk or a high risk trauma? Okay. Next, you should consider that CT has a higher accuracy for occult fractures. However, the downside of CT is higher cost and also much higher ionizing radiation dose to the patient. So some high risk criteria are listed here. This is the Harborview criteria, which is used in the Hong Kong College of Radiology, which I think is a very good reference. So any presence of significant head injury, any focal neurological deficits, any pelvic or multiple extremity fractures, high impact trauma, death at the scene, accidents involving a fall of height from more than 3 meters, then you should view this patient as high risk and probably go for a CT. So we'll start with the basics, okay? Because for myself personally, I think you should know the basic anatomy, the normal anatomy, before you can find something abnormal. All right. So we look at the radiograph first in lateral projection. So we want to look at the cortex of the bones, first of all, to look for fractures. Okay. You just need to find the body and dens of C2, which is easily recognizable because it's the tallest structure here. Now you see C1 is here. C1 doesn't have a body, it has an anterior arch here and a posterior arch. Pardon me. So you come from here, this is C2, 3, 4, 5, 6, 7, T1. Okay. Then you have the intervertebral disc spaces. Of course, in radiograph, you cannot see this, the disc itself, but the spaces you are able to visualize. They should be approximately equal and shouldn't be widened or narrowed. Then you can look at the posterior structures, the spinous process, okay, the lamina here, and the facet joints. Okay, this is a very nice diagram which I like to show my students usually. Someone has very nicely zoomed in and highlighted the normal structures here. We can see once again, this is C2, the body. This is the dens of C2 or the odontoid pack. This is anterior arch of C1, posterior arch of C1. And then here you can see the prevertebral soft tissues. This will be important later because if this is thickened, you have to suspect there might be some prevertebral hematoma associated with the fracture. There is also this cortical ring here, which is called Harris ring. It should be intact. If it's disrupted, then you might suspect there might be a C2 fracture. All right, moving on. Sometimes, okay, you've looked very carefully at the cortices of the bones, and then you don't find any fractures, right? Okay. Another very important thing to look for is the alignment, because disruption of the alignment can give you clues on whether the fracture, there is an occult fracture, or there may be soft tissue injuries associated. Okay, so you can see the green line here is the anterior line. This corresponds to the anterior longitudinal ligament and is anterior to the vertebra. Okay, the orange line is the posterior line, which is here. It corresponds to the posterior longitudinal ligament at the back of the at the posterior aspect of the vertebral body. And then finally, this red line is the spinal laminar line. So this corresponds to the anterior-most edge of the spinous process. So while you cannot see the spinal cord in radiograph, you can see the space in which you expect the spinal cord to run, which is in between the posterior line and the spinal laminar line. So if you see that this vertebral body may be displaced anteriorly or posteriorly, this may cause this space to be narrowed, and then you can suspect there is a spinal cord injury, although you do not see it on the radiograph. Okay, this is similar, it's just a diagram. I think I've already mentioned all this. But regards to prevertebral hematoma, not all C-spine fractures are accompanied by prevertebral hematoma. So if you don't see soft tissue widening here, you shouldn't be complacent if the patient is clinically showing symptoms. All right, that was the lateral radiograph. So now we move on to the AP. So once again, you can see the vertebral bodies here. You trace all the bones, look for any cortical discontinuity. So sometimes on the AP, fractures can be subtle, and the upper cervical region is not very well visualized due to the mandible. Okay, so sometimes you can't see the C2. You want to determine what level is your injury. You just look at the ribs. Okay, so this is the first rib. First rib corresponds to T1. So this is T1, so you just count up. Okay, so another thing to note is the alignment once again. So centrally, you have the spinous processes. They should be all in a straight line. Okay, you also have the pedicles, two pedicles, one on each side laterally, which also should be in line. So if this alignment is disrupted, although you don't see a fracture, patient may have a ligamentous injury, a rotation injury, or some subtle fracture. Okay, now this is what we call the odontoid peg view or an open mouth view. So as you see, patient has opened their mouth by taking the radiograph. We can visualize the odontoid peg and the lateral masses of C1 and C2 nicely here. So the distance between the peg and the lateral masses on C1 on both sides should be approximately equal. Okay, and then the alignment between the lateral masses of C1 and C2 should also align well. Okay, so this is one pitfall in interpreting this radiograph. So if the patient is rotated, you may see that the distance between the peg and the lateral masses of C1 is not equal. You see it's smaller on the right side. However, when you look at the C1 and C2 lateral masses, they are still in good alignment. So this patient is actually rotated and does not actually have a true ligamentous injury. Okay, so once you familiarize yourself with the radiographic anatomy, then it becomes much easier to interpret the CT because a lot of the structures are similar. Okay. If you see the CT on the sagittal view here, this is taken at the midline. It's basically the same as the radiograph. You are looking at the vertebral bodies. Okay, this is C2, the dens of C2, then this will be 3, 4, 5, 6, 7, T1. Okay. You can also see the anterior arch and posterior arch of C1. And you can see the spinous processes. Okay. So if you're familiar with radiographic anatomy, CT will be much easier for you. And then it's not enough to look at the midline. I always need to remind, even my senior MOs, I need to remind them once in a while. You should look at the right and left lateral slices to view the facet joints. Okay, this is very important for facet joint injuries and rotational injuries. So you need to look, okay, see the occipital condyle is articulating with the lateral mass of C1 here. And then you can see all the facet joints here are nicely overlapping. This is the normal appearance of the facet joints. They're overlapping, described as like a shingles on a roof. Okay. At these right and lateral views, you will not see the vertebral bodies because I think they explain better on the axial. Okay. So when you are looking at the midline in the sagittal view, this is where you are looking at the blue line. Okay, you're looking through this plane, so you can see the vertebral body, you can see the spinous process, but you are not able to see the facet joints, which are more laterally here and here. Okay, so when you are scrolling to the left and right, you're actually looking at this plane where the facet joints are, but you won't be able to see the vertebral bodies. Okay, so what's the role of MRI then? So for radiographs and CT, they are fantastic to look at the bones, okay, to look at the cortex, but they're not as good for the soft tissue structures such as ligaments, the spinal cord, okay? That's why we say when we look at alignment, we're actually looking at for clues that there is some disruption in these structures, then we can proceed to MRI, okay? So, and when there is a CT confirmed injury, we can use the MRI to look at the extent of soft tissue injury. Okay, so this is some simple anatomy of the MRI in sagittal view. Okay, this is what we call the T2 weighted image, where you have the, if you look at the CSF here, it is bright or what we call hyper intense. And if we look at the fat, subcutaneous fat posteriorly, it is also hyper intense. Okay, so this is the T2 weighted image. So there's a lot of things labeled here, but just like the sagittal, the lateral radiograph and the sagittal CT, a lot of the structures are the same. Okay, you see the dents here. I'm sure you can recognize it. The dents here and C2, you can recognize it by now. C3, 4, 5, 6. But now you can make out the disc in between. Okay, which we couldn't see before on the CT and radiographs, just the space they were in. But now we can actually visualize the disc itself. And then we can also look at the spinal cord here. You don't see the bottom part here because it's out of the plane of this scan, but don't worry, the cord is not transected or anything here. So you can look at this, can look at the cord, you can also look at all the ligaments and the soft tissues here. All right. So if you're familiar with the basic anatomy of radiograph in CT, you can kind of recognize the normal anatomy of the MRI as well. So MRI specifically is good to look for cord edema, definitely, as seen here in this picture. This hyper intensity in the spinal cord, this is the normal colored or intensity signal of the spinal cord. This is abnormal, okay? This is hyper intense and represents cord edema. If you notice behind here, there's also some soft tissue injury. All right. So the length of the cord edema is one of the indicators for clinical outcome, and also where there is presence of hemorrhage. So as shown in the chart here, actually motor function recovery rate is much higher in non-hemorrhagic cord edema compared to hemorrhagic. So hemorrhagic cord edema, as seen here, this dark or hypointense signal is a poor prognosis indicator. All right, so that's we've gone through the anatomy. So now let's use the anatomy and look through a few injury types. So there's a lot of ways to describe cervical spine injuries. I've gone the way of classifying them by mechanism. All right. So first of all is hyperflexion injuries, which is the most common. So the spine is flexed anteriorly. So some injuries which fall under hyperflexion injuries are deflection teardrop fracture. There is also an extension teardrop fracture, which we'll go through later. Facet joint dislocations, either bilateral or unilateral. Hyperflexion sprains and clay shovelers fracture. So first of all, flexion teardrop fractures. They are characterized by flexion and compression, commonly at C5, C6. So you have a flexion going anterior, your spine is going anteriorly due to flexion force, and this causes downward compression onto the vertebral body down here, causing the fracture. Okay, so these fractures are unstable, and they may be associated with anterior cervical cord syndrome and quadriplegia. So some radiographic features, you have a sagittal fracture through the vertebral body, or a fracture of the antero-inferior vertebral body, which causes height of the anterior aspect of the vertebral body, which is your teardrop. Okay, there may be widening of the spinous process, interspinous distance posteriorly here. Because of the anterior, the flexion injury, the posterior aspect here is distracted. They are pulled apart. So you can have injury behind here, and the distance can be widened. There might be intervertebral disc narrowing, especially anteriorly. anterior dislocation of the facet joints, or rotation with an AP diameter that appears smaller than the other levels. Okay, let's just go through one example here. Okay, so let's trace the bones, C2, C3, C4, oh, C5. We see here anteriorly there's loss of height, okay, compared to the posterior part, and there's a small fracture fragment here. Okay, so we proceeded to CT for this patient. We noted that there's a teardrop fracture here, which was already seen on the X-ray, on the X-ray, pardon me. But we also noticed there's another fracture of the vertebral body above it, which is 2, 3, C4, which was not very evident on the radiograph. Then we go to the right, okay. There's some slight distraction of the facet joint here, as well as the left side. However, they are not dislocated yet. And then if we look at the coronal image, you can see a sagittal fracture through the vertebral body. Okay, so this is a flexion teardrop fracture. So we further proceeded to MRI for this patient because he had neurology. You can see here, it shows similar findings to the radiograph and the CT. You can see the teardrop here. Okay, however, now we can look at the cord. When we look at the cord, there are these very ill-defined hyperintensities with also some hypointensities within. So this represents cord edema and hemorrhage within the area of the cord edema. We also see a disruption of the ligamentum flavum posteriorly and the interspinous ligaments, causing some CSF leak and soft tissue edema here. Okay, so can you imagine that the force is going anteriorly? So your vertebral body is being crushed here, is being compressed, leading to a fracture here. And because because you're posteriorly, you have this distraction injury going here, and this stays here. So this space becomes widened, causing injury and tear. All right. So for the next patient, a similar case we see here. Okay, count from C2, C3, C4, oh, C5. There's loss of height here, and there's a fracture fragment. However, the lower cervical vertebra were not very well seen here due to being blocked by the soft tissue. So we proceeded to a CT. So once again, we see here that the CT shows that there is a teardrop fracture here at the anterior inferior part of the vertebral body. There's a sagittal fracture through the vertebral body. And here we can see there is retropulsion of the posterior aspect of the vertebral body. So remember, when we look at the CT, we cannot see it's a bit difficult to see the cord. You can see it, but it's not very clear. But here, this space now is being invaded by being compressed by this vertebral body. So you can suspect there might be some spinal cord compression at this level. So an MRI was done. Okay, it demonstrates the fracture. And sure enough, there is compression of the spinal cord here. You see hyperintense signal within the cord, which is edema. And then you have this hypointense signal within, which is hemorrhage. There is also some posterior ligament injury, as noted in the previous patient. Right. Okay, let's go to facet joint dislocations. So usually, you will see that there's anterior displacement of one vertebral body on another. Okay, the mechanism is similar. There's force fraction anteriorly, and then there's distraction of the posterior structures. So they can be bilateral, which is unstable. There's no element of rotation since both sides of the facet joints are dislocated anteriorly. However, there's usually a lot of soft tissue injury, such as disruption of the posterior ligament complex, the PLL, the disc, and also usually the anterior longitudinal ligament. And commonly, there's a lot of there is significant spinal cord injury. As for unilateral, they are usually stable. There is rotation because only one side of the facet joint is involved, and then usually associated with a monoradiculopathy that improves with traction. 30% of patients will have associated neurological deficit. Right. So this is an example of a patient. So on the AP view, we don't really see a fracture or anything. But if you look at the spinous processes at the midline, they are no longer in a straight line. You see, these are okay, midline, this is a bit to the left, to the right. This is much to the right, to the right. Yep. The alignment is all off. Okay. So when you look at the lateral, you see that, okay, this is C2, C3, C4. So C4 is actually anteriorly displaced over C5. Okay. And then if you look at the facet joint here, is a bit raised anteriorly, and you can see the interspinous distance is so wide posteriorly here. Okay, so I proceeded to CT for this patient. So at the midline, it will appear similar as your radiograph here. Okay, you see there's anterior displacement of the vertebral body of 2, 3, 4, C4 over C5. Posteriorly, there's widening. But now when we scroll to the right, we look at the right facet joint, okay, you can see, oh, the facet joint here has dislocated anteriorly. It's supposed to be here. Okay, like this is a normal facet joint. It's supposed to be here, but now it has moved forward here. Okay, it has dislocated. But when we look at the left side, there's just some slight distraction here, but it's not yet dislocated. It's still in a fairly normal position. So this is a unilateral facet joint dislocation. So okay, so this is we radiologists, we love our food and animal science, right? So when we look at the axial CT, the left facet joint, this is the normal appearance, okay? So it's like faintly looks like a hamburger bun here, you can imagine. Okay? But when the facet joint has dislocated, there's inversion of the hamburger bun. Okay, so now the hamburger bun looks like this. Okay, here's what it looks like on CT axial. Right, so this patient proceeded to have an MRI. Okay, so pardon me. So we see here once again anterior displacement of the vertebral body. We see some rupture of the disc anteriorly here. We see a lot of soft tissue injury posteriorly with widening due to ligament injury here. And then same like the CT, we see the dislocation of the facet joint here. So now a different patient, okay, pardon me. So this is a different patient. You see once again there is anterior displacement of the vertebral body. Now it is C2, 3, 4, 5, C5 over C6. Is you notice compared to the previous patient, the amount of anterior displacement is slightly more, it's about 50%. Okay, then when we look here, there is pardon my bad drawing. Anyway, there's a dislocation here on this side. So we proceeded to CT for this patient. So the midline view will look the same as the radiograph. Then you see here on the right side, there is dislocation anteriorly of the facet joint. And on the left side, oh no, we see there is dislocation as well. Okay, so this is the bilateral facet joint dislocation. So when we look at the CT axial, once again, we have the inverted hamburger on both sides. Right, so this patient had an MRI done as well. So you see there's this vertebral body is actually impinging onto the spinal cord here, this part. You see some cord edema here, this hyperintense signal. Okay, and then when we look at the facet joints, once again, you see the dislocation here. All right, so that's for the facet joint injuries. Now for hyperflexion sprain. So these are actually, the name sprain shows that they're injuries to the soft tissues without a fracture, okay? Some radiographic features which should raise your suspicion include kyphotic deformity, widening of the spinous processes posteriorly here, okay, and widening of the posterior aspect of the involve this space. MRI will be much better compared to radiograph to demonstrate subtle injuries to the soft tissues. Okay, so this patient is a 44-year-old female. She had sustained a fall. Subsequently, she had a second fall the following morning, and she developed complete loss of motor and sensation. Right. So her radiograph was unremarkable, but because of the significant neurology, the primary physician requested for a CT scan for this patient. So on the CT, we noted there are these very tiny, you can see here, bony fragments here next to the facet joint. Okay. There is also widened interspinous distance here posteriorly. And then there is some soft tissue swelling, which is might be a bit subtle to see. Okay. So these CT findings are actually not that abnormal to say that it will cause such a, complete loss of motor and sensation, such a significant neurological symptoms. Okay. So we proceed to MRI. Right. Where do we stop? Okay, here. So proceed to MRI for this patient. So the MRI explains the neurological status of the patients. So see here there's a lot of soft tissue injury here posteriorly at the paraspinal region, especially at the C5, C6 level, which we saw on the CT. It was widened, the space here. So there is disruption of the interspinous ligament and also the ligamentum flavum here. There's also disruption of the disc, and then there's a large amount of spinal cord edema, as you can see here. However, there are no fractures seen. So this is primarily a soft tissue injury. So lastly, for the fracture injuries is the clay shovelers fracture. Okay, so-called because they used to be found in patients who shoveled clay, which their shovels got stuck in the very sticky clay, resulting in injury. So it's a fracture of the spinous process of C7, usually a stress fracture. Nowadays, you will see them with motor vehicle accidents where there is muscle contraction and direct blows to the spine. And this is a stable fracture, and we'll see why. Right, clay shovelers, right? Okay. So this is a stable fracture because you see it's only involving the spinous process here posteriorly. It's only one column. There's no associated injuries in the rest of the vertebral body. All right. So now we go to hyperextension injuries. Okay. So I'll be covering two today, the extension teardrop fracture and also hangman fracture. So hangman fracture is a bilateral lamina and pedicle fracture at C2. Now, you don't really see it in hanging. You see it more commonly in high-speed MVAs and also diving accidents. Okay, they may be associated with anterolisthesis of C2. And if there is extension to the transverse foramina, you may suspect there is vertebral artery injury. And they are rarely associated with neurological deficit, and we'll see why. Predictors for spinal cord injury include displaced C2 and facet joint dislocation, as well as ligamentous rupture. Right. So I think we just breeze through this one. Type 1 is the most common, which is fortunate because this is the least likely to have a neurological deficit. There's only a hairline fracture. There's no displacement of the vertebral body. Type 2, there is displacement of C2, and there may have a disc and ligamentous injury. Type 3 is also displaced C2, but also with bilateral interfacet dislocation, as we covered previously. All right, so let's look at this patient. So the anterior view, you can see some subtle lucency here at the base of the at C2, but it's not that obvious. Okay, we look here. If you look carefully, you can see there's some cortical disruption. Okay, so a CT was done to confirm the findings. Midline, not very interesting, but as we look to the bilateral right and left, we see at the pars interarticularis of C2, there are fractures here. And this is relatively non-displaced. Okay, you can see here on the axial view. And is in this patient, the transverse foramen are not involved. Okay, next one is extension teardrop fracture. We already went through flexion teardrop fracture. Once again, is a fracture of the anterior inferior vertebral body, but this time instead of compressive force causing the fracture, there is an avulsion of this corner here by the anterior longitudinal ligament. Okay, it's unstable fracture, and okay, let's just go through the images. So on the AP is not very obvious. On the sagittal, this is, you can see, you can recognize this is the C2 by now, I hope. Okay, C2 at the anterior inferior body here, we can see a small bony fragment, which is the teardrop. Okay, CT confirms the findings, and laterally, there's no dislocation of the facet joints. Okay, we proceeded to MRI. On MRI, you can see there's a soft tissue injury posteriorly. You can see the avulsed bone fragment here. You can see that this black or hypointense structure is connected to the fracture fragment, which is our avulsion, which is causing the teardrop. Okay, there was no spinal cord edema in this patient. All right, one more type is the axial compression fractures, which I'll cover Jefferson fracture and also burst fractures of the rest of the cervical vertebra. Jefferson fracture basically refers to burst fracture of C1. Okay, they're commonly seen when diving headfirst into shallow water, and typically they are not associated with neurological deficit unless there is a retropulse fragment. They are commonly associated with other C-spine fractures. Okay, this is when our open mouth or odontoid peg view becomes useful. You can see here there's widening of the distance between the lateral masses. You can see that they have moved laterally on both sides, causing widening. And then now there is incongruence of the alignment between the C1 and C2. So CT gives us a better view on the axial here. The ring is broken anteriorly and posteriorly, anterior and posterior arch. And there's a tiny bone fragment here, which is an avulsion fracture which came from here, from the transverse ligament. Okay, next one is burst fracture of the rest of the cervical spine. So they are commonly found at the thoracolumbar transition zone, usually from heavy axial loading and fall from significant height. Okay, so radiographic features, we just go through the images lah. All right. So you have a very strong axial loading force causing the burst of the vertebral body. Here you can see there is not really anterior displacement, but here you can see there's posterior displacement, which we call retropulsion. Okay, here you can see how it looks like on the corona. There's loss of height. And here we can see that there's narrowing of the spinal canal due to this burst fragment, which has been displaced posteriorly. So MRI was performed for this patient. So you can see once again that there's posterior displacement of the vertebral body, and you can see there's a cord edema here. All right. So that's for the burst fractures. We're almost done. Last two. So other fractures include odontoid fractures and electroaxial dissociation. Odontoid fractures are fairly common, and many of them are seen in children, about 3/4. And the radiography may be subtle. So they can be classified according to Anderson and D. Alonso, which is the most commonly used, is based on the level of the fracture line, either the tip of the dents, the base, or going through the vertebral body, or C2. So unfortunately, the most common type 2, is also the most unstable and has poor healing. All right, here's one example, which you see that there's some loosened line here on the radiograph. And then when we look at the CT, it confirms there is a fracture at the base of the dents. Okay, finally, allantoaxial dissociation. It's characterized by complete disruption of all the ligaments between the occiput and the atlas. Is unstable and uncommon and frequently fatal, reported in about 31% of fatal MVAs. And they are more common in children due to their large head, and up to 50% are overlooked initially. All right. Okay. The slides are acting up again. for some reason. Okay, there we go. So there's anterior transection of the skull on the vertebral column, which is the most common presentation. Radiographic features include disruption of the normal alignment, and these are various distances which can measure to give us a clue that this we should suspect this diagnosis. So I won't go through into the specific details, but I'll just show you what they look like. I'm so sorry, my slides are causing some... Okay. So this is the alento-dense interval, which is between C1 and dense, the small distance here. This is the Bayesian dense interval, which is measured here. And this is the Bayesian and axis interval. All right. If these are widened, then you should suspect there might be alento-axial dissociation. This one, just one example of a very bad one. You can see here. On the CT, it shows that there is dislocation of the occiput from the atlas here, as well as large amount of hematoma at the epidural space. On the MRI, it shows there's disruption of the ligaments. You should expect there to be hypointense line here connecting the two, which is the alar ligament and the cruciate ligament, okay, which have been disrupted here. All right, that took quite a while. Okay, I hope that was helpful for everyone. Now we can take some questions.
Thanks, Hazwan, for the informative talk. I hope that our colleagues from the other departments have benefited from the radiologist's viewpoint on imaging indications, radiological anatomy, and the appearance of various cervical spine fractures. Okay, so going straight to the questions, we have two here. The first one of which is, are there any situations where we can proceed to a CT cervical without doing the X-ray first?
Certainly. Okay. So MRI will not be your first line of imaging, right? So it will be either CT or radiograph. Okay. So I think this will depend whether does the patient require a CT. Like in we discussed some of the high risk factors pretty far back. One of some like high energy trauma, fall from height more than 3 meters, death at the scene. So all these high risk factors, if it's present, you should probably proceed to a CT. So if you're going to do a CT, there's no need for a radiograph because it will give you the same information. Okay, so if you're planning to, if there's indication and you're planning to proceed to a CT cervical, no need for X-ray prior to it. All right. I hope that answers the question.
Okay. And the final question is, when should we do an MRI instead of a CT?
Okay. So this is actually related to the first question. You don't use MRI instead of CT. I mean, they are looking at two different things. CT is good to look at the bones, all right? So if you want to visualize the bony structures and all, and also should be used as a precursor to MRI. So if there is suspicion on the CT that there might be soft tissue injury or involvement of the cord, like when we look at the alignment just now, when we see there's retropulse bony fragments going to the spinal canal, you suspect the cord might be compressed and having edema. Then we'll proceed to an MRI to visualize these soft tissue structures better. So it's not really MRI instead of CT. MRI would follow CT if there's suspicion of soft tissue injury. Right. I hope that's okay. So thank you so much for having me. I hope everyone found it helpful.
Thank you for answering the questions. There's one last question, but I don't think we have time for that. So maybe Dr. Hazwan can type in the answer later personally.
Right. Yeah, I'll look at it.
Right. Okay, so I think that concludes our breakfast talk for today. Thank you everyone for attending. Thank you, Hazwan, for your talk.
Thank you so much. Thank you.